I'm delighted to be here, for one, because it's my first time in Australia, and my daughter is extremely jealous that I'm here without her. But also because I think everything I've heard and learned about Burnet over the last few years, and everything that I've seen over the last few days, convinces me that we are, in many ways, very similar organizations, and I hope I can convey some of that to you in the next, hour. In terms of the way we approach problems and the way we look for solutions, and the way we aspire to do more than just, what we might be trained to do. So let me not take more time because I do have I do have the intention of presenting for about 45 minutes and leaving perhaps 10 or 15 minutes at the end for a discussion. I've had ongoing discussions with many of you, and any that don't get completed here in this room, please feel free to catch up with us for the rest of the time that I'm here, or certainly over email. I am going to be speaking about Zero TB Karachi, which is a very particular initiative and an approach to comprehensive TB control in detail. But just to start you off, and for those who might have less reference about our group, Phil's already introduced you. We are now based out of Singapore. That's our sort of operational hub. We were previously based out of Dubai for several years, and then we originated many years ago, 15 years ago almost, from Karachi, which is where I'm from, where Uzma's from, and others who are now part of the founding board of IRD Global. We are operating in several countries in the region. It's Indonesia, Vietnam, and just this month, or this quarter, if you will, the Philippines, but also in Bangladesh, Pakistan, South Africa, Zimbabwe, and soon, we hope, in Nigeria. For those of you that are familiar with TB, these are simple statistics for others. TB, of course, is airborne. It is one of the top leading cause of infectious disease deaths around the world. It kills just under 2 million people every year. And the decline of TB incidence globally is really a very poor state of affairs. It's less than 2% per annum. When the global community has set itself a target by 2035 of decreasing, of achieving a 90% reduction in TB incidence and a 95% reduction in TB mortality globally, and to achieve those rates, to achieve that target by 2035, the rates of decline that we're going to need to see are going to have to be in the range of 20-30+%, not this, under 2% that we currently have. And so there's obviously a problem where we are with TB control approaches. That's also reflected in the burden in these countries. So this slide is from the most recent global TB report from the WHO, and it reflects, in terms of the size of the circles, the very many absolute number of patients that are there in places like India, which has over 2.5 million incident cases a year, but also China with over 1 million cases, and then countries like Indonesia, Philippines, and Pakistan with 500,000, and then smaller ones like Thailand and Vietnam. So there are many countries that see over 100,000. There are a few countries that see up to 1 million incident cases a year, and then there's, of course, India, which is stand by itself. Our team, and this is just to give you a sort of a reference point with regards to where we understand, or at least I understand where Burnet is at this point in time. We actually started seeing our first TB patients and working in TB just about a decade ago. And we started with a small program treating MDR TB patients in Karachi with the Indus Hospital. And over the last 10 years, we've built our team's capabilities and expertise, both in terms of expanding to active case finding, treating prevention, and treating comorbid conditions along with TB, but also the introduction of new drugs. My colleague here, Uzma, has been responsible for the End TB grant that you see here, funded by United in 2014, which was targeting the then introduction of new drugs, bedaquiline and delamanid, in about 17 countries. We've also been very fortunate that the Stop TB Partnerships TB Reach initiative has funded us almost every one of their grant cycles for an innovative approach to active case finding in some particular setting. In Asia, generally in the private sector, and in Africa, generally in the mining sector. So we've got as a group, a considerable experience looking for TB amongst patients that seek care in the private sector, as well as in the African setting in mining communities, as well as miners themselves. More recently, we've become what is called principal recipients for Global Fund. So we are now running large-scale Global Fund service delivery grants. In Pakistan, we are sub-recipients in South Africa, and we are hoping to be similarly associated with programs, Global Fund programs now in Nigeria. We've, along the way, done lots of small studies, used a lot of opportunities from small grants to build up the capabilities and the breadth of what we do, which has led to this larger service delivery programs now across multiple settings. One of the key initiatives we're engaged with is what's called the Zero TB Cities Initiative, and this was launched by a small consortium. This is by no means a closed consortium, and this continues to now, we're really looking forward to it expanding. But it includes IRD, the Stop TB Partnership, Center for Global Health Delivery, which is a Harvard center in Dubai, and a group called A&D based out of North Carolina in the US. And there are certain Zero TB cities that have embarked upon a very ambitious, comprehensive approach to TB control that includes search, treat, and prevention. And amongst them, Karachi today is by far the furthest ahead, simply because we were there in the beginning looking to be a Zero TB, and we were also the first one to receive significant funding to actually roll out Zero TB. But there's also the city of Chennai in India, Lima in Peru, Ho Chi Minh in Vietnam, and Dhaka emerging in Bangladesh. So now on to my focused discussion on Zero TB. So as far as this particular initiative goes, we were provided $40 million by Zero TB in 2016 and 2017 by the Global Fund to roll out Zero TB Karachi, which is a city of 20 million people. So I'll describe the interventions in greater detail, but essentially taking search, treat, and prevent comprehensive TB control strategies for a very large population of 20 million urban, South Asian megacity, if you will, plus 32 additional rural districts that we had already been responsible for. And then subsequently, we were awarded an additional $40 million to expand the Zero TB cities approach to two other smaller cities, Peshawar, which is about 5 million people, and Quetta, which is about 1 million people or 2 million. And then continue to work in the 32 districts that we have. So I just also wanted to give you a sense that this $80 million that we have received from the Global Fund is not all invested in one city. It's actually spread across 32 districts where we have routine TB programs that include things like, drug susceptible TB program management, otherwise known as DOTS, but also MDR TB. We provide half of the patients in Pakistan are treated by our group within the southern half of the country, and so we are a big MDR TB program provider along with the initiatives that are focused on Zero TB. So these are the 32 districts here in blue that highlighted, where we have what we call traditional TB programs running. The circles indicate where we have MDR TB treatment sites, also known as PMDT sites, and that's, as you can see, the lower half of the country. And then the orange cities, Karachi in the south on what is the Indian Ocean. Karachi is 20 million people, as I mentioned, and is our oldest Zero TB city. We started working there in 2016, sort of launched sometime by mid-2017, and Peshawar we launched in 2018, earlier this year in January. We have a third Quetta coming up that's in the process of becoming fully Zero TB. So what is Zero TB? Zero TB, in effect, is really looking at TB control from the perspective of having very intensive active case finding going on amongst all populations where you could possibly think of having TB or higher risk of having TB. You have treatment that is comprehensive, not just focused on DOTS, but also, of course, on drug-resistant TB, but also caring for patients in a more patient-centric way, making sure that their conditions other than TB are also cared for. Many of our patients have diabetes, are co-infected with hepatitis C, and in smaller proportions, certainly in Pakistan, are co-infected with HIV. But that is an important lesson in terms of patients' perception of what a TB program does for them. If you only treat their TB and they go back still unwell with other conditions, that's not solving their problem. That's counting off something on your list that I've treated this many people. So being more comprehensive in the way we approach introducing mental health, screening for depression and anxiety, which are very common amongst those that certainly have drug-resistant TB. And finally, prevention, which is something that almost no program in these high-burden settings does or even aspires to do. So rolling out household contact tracing for all household contacts, and then ensuring that all of those have been screened for active disease, and those that are left are offered preventive therapy. So one way of thinking about this, if you would, and for those of you that are familiar with TB REACH projects, is that each of those boxes, in effect, is almost a large project on its own. And what Zero TB aspires to do is coordinate all of those inputs to focus them on a small geography in a short period of time, to have the high likelihood of impact, because what we're not seeing is a rapid decline in incidence. It's less than 2%. And what we hope to be seeing are declines that are 20 and 30% per annum. So how do you get from where we are to where? So this is essentially one of the aspirations. And when we approach the city, it's a very large 20 million, public sector, private sector, not-for-profit charities. We were convinced by people who were wiser than us that it would make a lot of sense not to focus just on, say, the private sector, which might be easier to work with, where you might have more freedom to work, but to also continue to work to strengthen the public sector, to work to ensure that these not-for-profits that are already there doing good work, that you expand their capacities and capabilities. So working with people, and often when you have money and you have no need to work with people, it's easiest to, we can do this on our own. Working together with a lot of different kinds of people is hard work. One of the things we did from the very beginning, you see the logo on the bottom of the fist above TB, and in Urdu it says, "Come wipe out TB." We never put an institutional logo on the initiative. It was a logo that anybody and everybody could own. So if you were a public sector provincial TB program, you could use the logo. If you were a private charity hospital or a private, fee-based hospital or clinic, that logo could be owned by everybody. And that was despite the fact that we had some internal pressures from our own institution and our board to say, well, why aren't we stamping this with our logo? But I think that's one of the, again, somebody suggested we do this, and it worked out very well for us in the long run. But we have sort of invested almost equally in the public sector, in the private sector, and in the not-for-profit sector. So those funds that we have received have gone in to strengthen or to fill in gaps in these respective centers. So an illustration of what happened in the public health sector, there are 60 national TB program reporting sites. So they were linked up, strengthened, often gene expert testing, linked to supply, to picking up and transport of specimens. FAST sites are essentially 18 large public sector hospitals where we implemented a rapid screening and separation of individuals who were likely to have symptoms of TB, separated them from everybody else in the outpatient departments and the wards, screened them for TB, tested them, put them on treatment in a very, sort of the whole purpose of this is, and why it's called FAST, is doing that very quickly. We also introduced airborne infection prevention through UVGI lights, ultraviolet germicidal lights, and then mobile X-ray digital vans that pulled up to outpatient departments where long lines of patients were standing, and patients would then be asked, without screening them for verbal symptoms, they would be asked to get on and get a X-ray if they wanted, without a verbal screen, because a verbal symptomatic screen is an insensitive tool to find most of your TB cases. You'll find about a third of people who actually have TB also have symptoms. The other 2/3 can't really be identified or screened for by just verbal screening for symptoms. So you want to do X-ray screening, which is something that we instituted at large scale. Introduced Gene Expert in the public sectors in the sites that weren't high volume sites that didn't have them already. And we did the same. We improved quality of care and added prevention, and we linked it all up with a call center and a field force that allowed a person to be identified pretty much anywhere in the public, private, or not-for-profit sector, and they could move between those sectors and still be followed or linked through our electronic medical record, which is one system for TB for the whole city. And every patient essentially gets, from the point that they're identified through a screening program all the way to treatment outcomes, there's a centralized database that's accessible to a call center and that alerts the call center for people having missed either picking up the test result or not initiating treatment or missing a follow-up visit. So it's a very disparate and chaotic health system. We've put something in, we've plugged things in that allow us to monitor the flow of patients through a city this size. We did something very similar, of course, in the not-for-profit sector, and because you've seen the format, so again, introducing better technologies, better diagnostics, better treatments, comorbid infections, and prevention of infection. And finally, in the private sector, which had been really under-tapped in Karachi, but where we think up to 60-70% of all patients go first for treatment for TB symptoms, we set up what are called Zindagi centers or life centers, and these were small centers of 3 or 4 rooms with an X-ray, a physician, a nurse, and a gene expert machine, and they served as a hub for about 250 to 400 private providers around them. We set up 30 of these in the city of Karachi, and that allowed us to offer access between 8 a.m. and 8 p.m. to those patients who would never come to public sector sites. So we offered them standard diagnostics, standard treatment, and then they were notified back to the public sector National TB Program reporting sites. Again, something that's unique. We had a $2 million campaign that focused on both, what's called above the line media in the news, but also lots of other kinds of programming below the line, having auto rickshaws have ads on the back for getting yourself tested for TB. In the videos here, that icon or the person there is Yunus Khan, one of our former cricket captains, very easily recognizable in Pakistan, and he's come wipe out TB with me. The girl, you'll see this video later, is stigma reduction in a girl who's about to get married. The older lady on the bottom is somebody who's seeking care in the private sector, and so informing patients that now you have access to free testing and free treatment for TB in the private sector. And then a social movement established with the use of 40,000 schoolgirls in what's called the Kiran Sitara program. So we engaged volunteer schoolgirls in the lowest community public schools to conduct household screening for symptomatics with us across the city. And a little bit more about them a little later, but here's a video on communication.
मैंने तो सिर्फ सांस ही ली थी।
अम्मा, मैं ये नहीं होने दूंगा।
बेटा, चलो हमारे साथ।
टीबी से लड़ रहे लोगों को इलाज दो, सजा नहीं। 2 हफ्ते की खांसी को हल्का ना लो। आज ही आओ टीबी मिटाओ या 6 पत्ती के निशान वाले सरकारी, निजी अस्पताल या सेहतमंद जिंदगी सेंटर से टीबी का मुफ्त टेस्ट और इलाज करवाओ। हुकूमत पाकिस्तान और सूबाई हुकूमतों के साथ आओ टीबी मिटाओ।
So she gets happily married, goes home, but stigma reduction in terms of don't hide the disease, come out and get tested. You saw in the back of the cricket player, you saw the vans, the X-ray vans. And the thing with X-ray vans is they're not in fashion anymore, mobile X-ray vans. And it's really odd because 100 years ago or more, Marie Curie actually took some of these early mobile X-ray vans into the field, into the battlefield in Europe. And then subsequently, mobile radiology was one of the principal ways by which the military certainly provided care during wartime. And these were later adapted when TB control became important to countries. These were later adapted to very commonly and routinely used mass screening X-ray mobile platforms. Yet somehow in the 80s and 90s, the WHO expert committees decided that it wasn't really practical for high burden countries to follow through with what had already been done in Europe and North America, in the Soviet Union, in Japan, I'm sure here in Australia, and that it wasn't practical and that they should be not sort of prioritized any longer. And it eventually just sort of fell off of what countries did. And they all went to DOTS, which is, once you're sick, you go to a health facility and somebody then watches you take a pill every day. And that is not what was done in every other place that they actually have controlled TB. And there are so many examples of using just mobile radiology from so many different countries that also then surprisingly remind us of how similar when we reconceptualize it without actually knowing the history, that you come up with the same solutions that people already had 100 years ago or less. And what does tend to happen though is because there's not a continuity in the way mobile X-ray vans were designed, what is now manufactured and available in some instances are so large and so unwieldy for the many settings that we operate in. That on the bottom right, for example, these are $500,000 X-ray units that you cannot take into a slum in Karachi. You can't even take this onto a main road in Karachi because it's just too big and too unwieldy. And so there's a lot of relearning that our teams had to do in a practical sense, but it's also striking that how similar our situations of having patients line up in fields and get X-rayed without disrobing. Because one of the recommendations if you are doing a national prevalence survey with WHO is that you do disrobe. And nobody knew, when we asked, they said, well, yeah, you got everybody disrobes because that's what you do in national prevalence surveys. But 70 years ago, nobody was disrobing. And if you haven't noticed, I'm sorry, I should point that out here. Look at the bottom here. It says, no disrobing necessary. They had the answers because they were doing the things that were right at that time, but then of course all of this is forgotten. We now have no requirement for disrobing in our mass X-ray screening program. We have 55 of these vans at $105,000 each. So for the cost of about 5 of those larger vans, we were able to assemble almost 5 of them and just have a lot more access to radiology. Within the van, there's a digital X-ray system. There is a computer-aided detection for technologies because you don't have a radiologist. There's a CAD for TB system that allows you to generate a risk score for how probable or likely it is that that X-ray is associated with TB illness from previous studies. And based on that score, you can then determine if somebody should be sent for a gene expert test. And those that have a high score are also given a printout on the van of their X-rays. The X-rays can go into, the small vans can go into prisons, they can go into small courtyards at hospitals, so very versatile in that way. Because of that very intensive campaign, national campaign, and the way we branded these vehicles as well, wherever they turned up in the community, we also got free advertisement from local media. They turn up and do stories on the vans and stories on what was going on with patients and in their lives. And that was really helpful because over the course of a year, while we did spend a lot of money getting it off the ground, this is now an incredibly recognized, like you see them all over the city at all times of the day, and people will know if I have TB, I go to the van, more than they might even know that I go to a facility. And so we've used them at outpatient hospitals on the top right, OPDs. At the bottom right, we've used them in workplaces, in fields. We've used them for women-only camps where we have more conservative populations in Peshawar and the northern parts of Pakistan. We've used them in mining populations, coal mining here in this instance, driven them out into the, if you will, the boondocks and had large groups of miners being screened. In addition to that effort, we've had this 40,000 schoolgirl youth engagement program, and this really is in close coordination with the Department of Education and working with the Department of Health. And we train these girls over 6 sessions of 2 hours each in communication skills, leadership, self-awareness, planning activities, not just our activities, but their own life and school, etc., and homework. And about health and community-based screening for disease. And these girls allow us to access special populations that include other girls and women. Because many times when we take a van out into a public space and we park it and ask people to come on, 70% of the populations tend to be men in our setting. It's only 30% that are women. But when we have the young students shown here organizing this camp with our vans turning up, it's the other way around. 70 or 80% of the people on board now are girls and women. And we have the highest prevalence of TB in our population is in fact among young adolescent girls and young women, which is very different than many other kinds of environments. So we were particularly looking at them. And Phil mentioned the whole aspect of a social movement, and I think that's important for us to recognize that you can have a glitzy $2 million campaign, talking about TB and harm and stigma reduction, but what you really want to leave is embed upon a large part of your population this thought that if there are signs and symptoms of TB, or if you've been exposed, that you must seek help, and there are very specific ways to seek that help. And so we've made that, and we've internalized that within a large cohort of young students who hopefully are sharing that information within their families and amongst peers. Here's a video that explains what they do.
लोग जब कहते हैं ना कि ये लड़की इसको इतना ज़्यादा पढ़ाने की क्या ज़रूरत है, इसमें तो वैसे ही घर में बैठ के काम करना है, सफाइयाँ करनी है, और लड़की को इतना आगे क्यों बढ़ाया जा रहा है। तो उनके कहने पर कभी कभी ये ख्याल आता है कि काश मैं लड़का होती तो ये लोग मुझे इस तरह नहीं कहते। मेरा नाम सना इमरान है और मैं 13 ईयर्स की हूँ। किरण सितारा प्रोग्राम मैंने 1 मंथ पहले ज्वाइन किया था। हमने सीखा कि लोगों से किस तरह बात करनी है, हम खुद को किस तरह जान सकते हैं, हमारी सेहत किस तरह अच्छी रह सकती है, हम अपनी कम्युनिटी का लीडर कैसे बन सकते हैं। जब मुझे पता चला कि ये इसमें लोगों की भलाई है, इंसानियत की खिदमत है, तो मैं घर गई। घर में रात के खाने पर सब मौजूद होते हैं, तो मैंने दादा से और दादी से परमिशन ली कि मैं हमारे स्कूल में ये प्रोग्राम है किरण सितारा जिसका नाम है, और जिसमें हमें मालूम करना है, बताना है, लोगों की मदद करनी है, खिदमत करनी है लोगों की।
भाई सना ने खुश होकर मुझे बताया कि मैं किरण सितारा में शामिल हो रही हूँ, मेरा प्रोग्राम है घर घर जाके मरीजों को ढूंढना। हमने बोला बहुत अच्छी बात है, अगर आप ये काम कर सकती हो तो कर लो।
हम लोग खुद ये चाहेंगे कि हमारी बच्ची आगे से आगे तरक्की करे, जो ये करना चाह रही है, इसकी ख्वाहिश है जो वो ये पूरी करे।
हाँ, एक लड़की थी, तो उसे लेना था, पार्टिसिपेट करना था, लेकिन उसके ब्रदर ने और उसकी मामा ने उसे बिल्कुल इजाज़त नहीं दी कि वो ये काम करे। मैंने उसको साफ मना कर दिया कि नहीं, तुम घरों में नहीं जाओगी, लोग क्या सोचेंगे, तुम लोगों के घरों में जाओगी किस तरह लोग कहेंगे। हालांकि उसने आधी बुक्स पढ़ भी ली थी, लेकिन जब फोल्डर्स हमें दिए गए कि लोगों के घरों में जाना है, तो उसके अम्मी अब्बू ने बहुत बड़ा रिएक्शन किया और उसे बिल्कुल बुरे तरीके से मना कर दिया। लड़की इतनी उदास हुई थी, उसको इतना शौक था काम करने का, लेकिन फिर भी उसके घर वालों ने उसे परमिशन नहीं देके उसका दिल तोड़ा। वो बहुत उदास हुई थी। सुनने को कुछ लोग जो होते हैं पुरानी सोचों के मालिक, वो कहते हैं कि ये लड़की तो अभी से ही बाहर निकलना इसलिए शुरू कर दिया है, अभी तो इस तरह कर रही है, बड़े होकर पता नहीं क्या कहेगी। लेकिन हमारी टीचर्स ने बताया है कि जो सबसे बड़ा रोग है वो है क्या कहेंगे लोग। तो ये क्या कहेंगे लोग वाली बात टीचर कहती है इसे छोड़ ही दिया करो। मैं अक्सर अपने दोस्तों के साथ ज़्यादा निकलती हूँ, स्कूल से जाना होता है, बहुत थोड़ा सा डर लगता है, लेकिन जब बाहर निकलती हूँ तो फिर वो डर और बढ़ जाता है कि अभी लोग तंग करेंगे। मेरी फ्रेंड मुझसे बड़ी हैं, तो वो जब आके बताती हैं तो थोड़ा सा खौफ होता है कि कहीं मेरे साथ भी ऐसा ना हो, कोई मुझे भी ऐसे रास्ते में तंग ना करे। मैं उनको कहती हूँ जाहिल अनपढ़ गवार, खुद तो पढ़ते नहीं हो, हमें पढ़ने दो, बस इतना कह के चली जाती। जब मैं अपने मोहल्लों में और गई, लोगों ने इतना सख्त रवैया रखा, बिल्कुल बात नहीं करी और गेट भी बंद कर दिया। लेकिन फिर भी मैं गई थी उनके घर, दोबारा गई, उन्हें दोबारा समझाया। इस वजह से मुझे काफ़ी मेहनत करनी पड़ी ताकि मैं अपनी बात पर कायल कर सकूं, कर एक अच्छा काम है। तो मुझे बहुत अच्छा फील हुआ कि मैं अब इतनी इस काबिल हो चुकी हूँ कि मैं लोगों की हेल्प कर सकूँ। जब मैं किरण सितारा प्रोग्राम में पार्टिसिपेट किया तो पता चला कि लोगों की खिदमत करके लोगों का इलाज होता है हमारी वजह से, तो कितनी खुशी होती है। जब मुझे डॉक्टर बनने का भी ख्याल आया, जब मुझे टीचर्स पढ़ाती हैं और वो हमें सिखाती हैं, तो मुझे तब भी ख्याल आता है कि मैं भी बड़े होकर टीचर बनूं और लोग बच्चों को सिखाऊं, उन्हें पढ़ाऊं, तब भी मुझे टीचर का ख्याल आता है। कभी टीचर का ख्याल आ जाता है, कभी डॉक्टर का, बड़े होकर पता चलेगा।
So this chant that they're crying out, it says "Step forward, Kiran Sitaras," which is the name of the program, and then for TB, it's "Step forward and wipe out TB." And so we brought 10,000 of them together in December last year, after 1 year of them working into an arena where lots of politicians and others turned up. But bringing them there really brought a whole level of energy to the program and a lot of press coverage, of course, but also the chief minister of the province, who is the highest political officer. And we were able to then entertain these young schoolgirls who, think about it, they're from Pakistan, urban slums, public school girls who've never ever been to a concert. And they had a pop singer, very well known, come out. They had the cricket icon. They were signing autographs, 10,000 girls. cheering like the days of the Beatles when they arrived in the U.S. from England. And we had the chief minister who was there in the center of the picture, then award schools and girls performance awards. And because when we invited him, he said he's only going to come for 20 minutes. But of course, you give a politician a free crowd of 10,000 cheering girls, that's like oxygen for them, right? So he stayed for 2.5 hours. The event was 4.5 hours long that day. And he sort of broke all kinds of protocol and walked back through the audience of girls taking selfies, who were taking selfies with him. But before he got off the stage, because of the 10,000 girls saying, "Step forward and wipe out TB," he started chanting the same thing. And we had him on video saying, "Step forward and wipe out TB." And then when the chanting stopped, he says, "I am committing our government to wiping out TB from my province." And then, of course, we took those videos back to him and said, "Sir, this is what you promised." and he has now committed 300 to scaling up this program to 300,000 schoolgirls, the Kiran Sitaras, in support of active case finding for TB, which is several $1 million from the government. But that's a kind of thing that we need to do in TB, which we don't often do because we're very project oriented and we're either medical or public health or para health folks. And we approach programs and diseases from that very narrow perspective. And so communications, social movement, and engaging with politicians is hugely, hugely important. And while all of this was happening, somebody you will probably recognize heard about this program, and then she recorded a video and sent it to us before the event to play on that day.
Hello everyone and Assalamu alaikum. I am so happy to learn about IRD's Kiran Sitara program and how you are involving young girls in the campaign of our TB Mitao in Pakistan to eradicate TB. And this is something really important, that you are involving young girls and focusing on their health and their education, which are two most important things for girl life towards empowerment. And we have to remember that girls are not a burden, they're not a liability, but they are a resource and an asset for a country. And if you want a better economy, a better country, we have to invest in girls. So I really appreciate the work that you are doing and focusing on young girls. And I'm hopeful that just as you have done work in Sindh, you also can focus and extend this work towards KPK, Balochistan, Punjab, Gilgit-Baltistan, and I can see a very positive change. So thank you so much for all that you have done and wish you good luck.
So she's, for those of you who might not know, this is Malala, the young girl who was shot in the head by the Taliban and then eventually was also awarded a Nobel Prize. But she's now she's a student, an undergraduate student at Oxford, and we're in fact meeting her next. She's invited us to meet with her next month to consider the Malala Fund scaling up the program to 1 million girls entering into this program every year in the pursuit of diseases in your community. And I think, again, this is just reflective of taking a different approach to communications, to social movements and disease control than many of us in our very traditional medical, public health, sort of training are accustomed to. While we're on that topic of doing things that non-traditional, this is something else that was very uniquely part of this initiative, this $80 eventually $1 million grant. And this included a $13 million investment by Global Fund into expanding our social enterprise, that's Zindagi Center that I mentioned, that hub where fee-based care was provided for the working poor in the private sector, and with 250 to 400 GPs networked into them. And we went from 3 in Karachi to 30 in Karachi and 30 in the rest of the country, and we now have 61 of these centers. And these centers are the principal way in Pakistan where we are now engaging the private sector directly to refer patients for standard diagnostics and treatment for TB. And of course, this is now also being considered for other diseases. The first one, we have had meetings here with Margaret Hellard yesterday, were on using this for hepatitis C elimination, this network, and others. And so what's also happened is we have seen, because of this investment in the private sector, rapid increases in the proportion of patients that are now being notified from the private sector itself. So there's a 69% increase in TB case notification overall for these quarters that are being compared here between 2016 and 2017. But even within that increase, there's a marked increase, there's a 226% increase in the proportion of patients that are being reported from the private sector. So we are finally finding those very large numbers of private sector patients that were previously not being found because there were very, if you will, old school approaches being adopted to engaging the private sector. What this is also done because of the number of patients, if you will, presumptives that are being identified, is that the gene expert testing volumes shown here on the left axis in increments of 5,000 increased from somewhere around 15,000 a quarter to now about 45,000 a quarter. And recently we've had to sort of think through if we could actually sustain that level of expenditure for our gene experts, and really trying to improve our algorithms to be much more, to increase the yield of our positivity rate. So you'll see that going from 6 or 7% to 11% more recently through the use of predictive analytics as well as artificial intelligence. More for those of you that are interested later. And in the midst of all of this, we've done over 500,000 x-rays right now. This is data for the first 400,000 till June 2018. So for comparison, on the first column, you'll see facility-based symptom screening. We did almost 3 million symptom screens, so this is the poor man's screening. And we found 5% of those people that were screened were presumptive TB. And then you needed to screen 384 individuals verbally to find one case of TB. When we did the same with chest x-ray at the same facilities, you needed to screen 76 people with an x-ray to find one case. So that's 4 times as less. That means with 4 times as fewer screens, you're able to find the same number of patients you are, which means 4 times, often the 4 times the lower cost, and certainly the 4 times lower even in time. And we have done this in the communities where we find, again, similarly low numbers that they need to screen. 1 or 2 places that we tried that didn't work is factory workers. Factory workers, surprisingly, in multiple settings are outside of very specialized populations that are dealing directly with silica products or marble. Factory workers are healthy. They're factory workers because they are healthy and they don't have TB. And so that's not the first place you want to start looking for TB in many of these urban settings. Now that may be very different if you're looking at it for silica-based manufacturing. And in prisons, similarly, we're finding that it makes a lot of sense to do X-ray-based screening. What this has done over a course of short 6 months in 2017 is increased case notification by about 17%. It takes a long time to launch something this intensive in terms of capital investments, operationalizing them and getting them off and the training for HR. And we are now in our first full year of implementation this year in 2018. For the first 2 quarters, we do anticipate that we're going to cross 30,000. So within about a year of implementation, we anticipate that we'll have increased case notification by 30%, which then brings us into the potential realm of having an impact of the epidemic where you might actually conceivably have reductions that mirror these increases in case notifications. But that's for the prevention arm. We've also had very dramatic increases in pediatric TB notifications through the introduction of physicians and nurses in large pediatric outpatient department, public and private hospitals. And this was following on top of, in 2013, a government-led, NTP-led scale-up of pediatric TB notifications and efforts, interventions already. So that had started in 2013, and you see that increase. And in 6 months of 2017, we brought a further increase on top of that. And in the full year of 2018, we anticipate for the first time we're actually going to double case notification, even from the higher baseline that followed from the government intervention already. So even when governments do work, or anybody does good work, you can still find more childhood TB. And that's one of the most surprising things we've learned, because I was never aware of much of this until people like Steve and others in our group for HANA made it a priority globally that childhood TB is something that you really need to look for aggressively. So in any setting, I would highly recommend that you look for this, not just for increasing your notifications, but also because of what it implies for these children. And we've done this and repeated this in multiple settings, the 2 zero TB settings in Karachi and in Peshawar, and then the city of Lahore as well. And wherever we look for childhood TB, you will find a lot of childhood TB. And this is not sort of loose classification of childhood TB. This is a very tight classification that people like Farhana and Steve and others in their committees have set the guidelines for. One of the other things we did was really focusing on prevention. So this scale up of prevention for the first time in a large urban setting like this, using the 3HP regimen now, but initially we started with IPT. And so the experience with IPT, which is 6 months of daily isoniazid, was that we had poor uptake and high loss to follow-up, or dropouts, if you will, sorry. Whereas with 3HP, we've had substantially better uptake and significantly lower dropouts. And that's simply because the 3HP regimen means you only need to take it once a week for 12 weeks, as opposed to, once daily for 6 months. And with the likelihood that longer regimen is associated with probably more adverse events. So there was a greater uptake, and we've now, as a program, decided that we are scaling up 3HP. Challenge, of course, is that it is an expensive regimen right now, and there are other combinations we're going to be looking at as well. We've been working with David Dowdy and his team to model our approach in Zero TB, because we want to be able to convince governments that this kind of upfront investments in a focused geography is important for both the political gains in terms of recognition in a country, but also demonstrating that the needle can move even in countries like Pakistan and Indonesia and the Philippines and Nigeria, and that if you do make that investment now, there are downstream savings to human misery as well as to financial benefits to society. And we've done this modeling with David, whereby you can take a look at the combination of different interventions, active case finding by itself, preventive therapy by itself, the two together, and things like that. And you can really get a sense of what rate you would expect incidence to decline at over a 5, 10, and 15-year interval. We've also done detailed costing studies comparing the different active case finding models. And just as a summary, the principal driver of the cost of active case finding in our instance really is the cartridge cost for gene expert testing. But if it costs $227 for symptomatic screening by itself, it costs us $387 if we add a chest X-ray. So for that additional $150, you're finding 3 times as many patients. The yield is 3 times as high. So yes, it is more expensive to do X-ray based screening, but you find 3 times more patients for about 3 or 4 times less work. So it is more feasible, more scalable, and more efficient to do it this way, but it does come at a cost. There have been many challenges and solutions, and I won't bore you with them. I'll leave 10 minutes for our discussions, but I do want to just end up on the fact that this is not an easy thing to do. There are logistics and human resource challenges that completely drown you and your teams in terms of any hopes you have of launching a successful Zero TB project. There are always funding gaps, despite the fact that you've read very large numbers on our slides. But there's always things we don't have money for, or the Global Fund, as a donor, makes it eligible once you've spent that money. And then we've also, we had a warehouse fire where about, $2.7 million worth of Gene Expert cartridges and stuff just got burnt up over Christmas. And thankfully it was all insured, and we did not interrupt our operations because we had stocks in the field as well. But $2.5 million, when I've known running TB programs with no money, but when that burns up overnight, you can't sleep for 5 nights. But thankfully, it was an externally sourced professional warehouse, insured, and so it's all got replaced. Now, having said that, so what we have now become as Karachi, and this is my last 2 slides, is that we are a must-see place for Zero TB aspirants. So we have had visitors from many different places, but most recently, just last week, we've had the Nigerian National TB Program and the State of Lagos Health Department leadership visit us. That's the National TB Program Manager in the purple dress. She's standing there, come wipe out to TB. But they spent a week with us. They went through the mobile X-ray screening processes, into the public sector hospitals, into the private sector clinics, and the GPs, the girl program that's in the center. The girls are reading the Nigerian national anthem, singing the national anthem when they came in, and we're delighted because we're able to become a place. Karachi is not some place you want to visit otherwise. As sad as it is, and I live there, but it is one of the least livable cities in the world. It's like the polar opposite of Melbourne, right? But it is, in this instance, for those of you interested in TB, it is a mecca for zero TB, and I would encourage any of you that would want to come and take a look at this. The Nigerians came, and they are what we call zero TB converts. After 5 days, they went back. We now have a zero TB Lagos approved, and we are finalizing the contracts next month in Geneva with them, and we're looking forward to launching the zero TB Lagos along with the Nigerians, of course, in January. So thank you very much. I have all these partners and so many people in addition to myself and Uzma who work on this. It's just not possible to even name them on a slide. But thank you.